Okay, so welcome everyone. Thank you for joining us today for the KT Canada seminar series. Today, as you have seen by the invite, we're very happy to have Dr. Monika Kastner with us. My name is Guillaume Fontaine. I'm an assistant professor of implementation science at McGill University. I'm also on the advisory committee of KT Canada, and I have the pleasure of moderating this session. So if you have any question during the talk, you can send those via the chat box, and Megan will read those questions out at the end of the session. You can also raise your hand if you'd like to unmute and say your question as well. Dr. Kastner's presentation will last around 40 minutes, followed by around 10 to 15 minutes of questions. So a little bit about our presenter today. Dr. Monika Kastner is the research chair in knowledge translation and implementation at North York General Hospital, an associate professor at U of T and the Institute of Health Policy, Management, and Evaluation, and also at the Department of Family Medicine and Community Medicine. She is also the lead of the Diabetes Action Canada Knowledge Mobilization and Implementation Science Program. Her goals are to improve the health of priority populations and advance the science and practice of KM and implementation science. As a health services and systems researcher, her work focuses on improving the health of priority older adults across diverse intersecting identities who live with multiple chronic conditions and social frailty, using innovative eHealth technologies that optimize healthcare delivery, clinical decision-making, and also improve patient outcomes. So please join me in welcoming Dr. Kastner. And Dr. Kastner, the stage is yours.
Great. Thank you so much for the introduction, Guillaume. And thanks everyone for joining this seminar today. So I'm going to be sharing our work on developing KeepWell, a little bit about the results, and also some of the learnings and challenges that we encountered in developing and evaluating this tool. Okay. So I'm just going to start with the challenges and why we even developed this tool in the first place. So we all know that by year 2050, our population is aging. 2 billion people will be 60 years of age or older, and more than half of older adults live with multiple chronic conditions such as diabetes, arthritis, heart disease. So the problem with challenges or problems with chronic disease management is then less than half of older adults actually receive the care that's recommended. And older adults with multiple chronic conditions often receive large quantities of complex interventions from multiple providers. So they end up not doing anything because it becomes too complex to manage on their own. Information is often conflicting, leading to confusion, and non-compliance with recommended treatment is what we typically see with older adults. So self-management strategies are one potential solutions, but they have not been well operationalized. So studies of older adults with the highest risk for chronic diseases are also lacking. So in particular, older adults who identify as racialized, older adults new to Canada, women living in under-resourced communities, and if they have depression or social isolation, this also makes things very difficult for this population. So there's a number of gaps in chronic disease management. So existing strategies seldom are developed for older adults. So that's a major problem. They don't involve older adults in their design and their development. It's often that these self-management strategies are developed for a single disease. So we see a number of tools for different diseases like diabetes, for example. And the other problem is that they're not deliberately created for specific combinations of chronic diseases, such as common dyad is diabetes and heart disease. And they don't usually consider the health priorities of older adults. And I think this has become extremely important in the last 5 years. And they also don't consider the whole person. So not just their physical, but their social and emotional well-being are not considered in these tools. So this led us to then thinking about KeepWell, which was not initially called KeepWell, so it went through a number of iterations in its name, and it's our patient partners actually that named KeepWell. But at the time that we thought about developing a solution, we had all of those gaps in mind, like to address all of those gaps. So I'm just going to jump in and just describe what KeepWell is. It's a web-based application that responds to the challenges of self-management for older adults with multiple chronic conditions. And it was really designed to motivate older adults to make lifestyle changes and engage in self-care. And the philosophy behind this tool is that it's everything is according to what the user, what their needs, their priorities, what they're ready to work on, what they feel they're comfortable with to do. That's the whole philosophy of KeepWell. And it's not about telling people what they're not doing well, but it's to try and support people in figuring out what little changes they can make to improve the way they feel with the chronic diseases that they're living with. So the innovation behind KeepWell is exactly that. It incorporates behavior change approaches to facilitate self-management and engagement. So everything from goal setting, customized recommendations, tracking, gamification, reminders, resources, instructional videos. So there's a number of different features, which I will get into in a moment, that we hope and we thought at the time that we had design KeepWell that makes it more innovative than what's out there today. It has a multi-disease focus, and I think that's one of the main innovations. It can generate lifestyle advice based on a complex algorithm that integrates any combination of the top 10 chronic diseases that older adults live with. So, and here are some of the disease dyads that we actually created lifestyle advice on. And so this was based on evidence both from our systematic review that we did that outlined some of the common chronic disease dyads that older adults live with, as well as other literature. So we try to really address these combinations the most. So the key features are listed here, and I'll just dig into very briefly. So we have an avatar health coach, and it's a very rudimentary avatar health coach. Like nowadays, we have all kinds of really interesting things like AI based coaching. So this is really just the beginning of what we thought would be helpful for users that they walk through the health prioritization and goal setting exercise. So the app, you go in there and there is like an audio voice coaching you through all of this. And the voice of all videos and audios on KeepWell is by the same person. So it makes people feel like there is someone there with them. And obviously, as I mentioned, there's more sophisticated ways of doing that now. But at that time, we were trying to accomplish that piece. So there's also a health risk questionnaire, which covers three risk dimensions. So a health background, which is mostly the physical health, then lifestyle areas, everything they do in their lifestyle. There's a set of questions around their social and emotional well-being, and this is where we're trying to think of the whole person, so not just their physical, but also their lifestyle and social and emotional well-being. And it generates an evidence-based action plan representing customized recommendations across 6 lifestyle areas. So physical activity, nutrition, smoking, alcohol, caffeine, and bladder health. So those are the common lifestyle areas that older adults care about. So then that generates a health profile summary. So these are really just responses. It shows the responses to all the questions. And we found that a lot of times in self-management, this is not done. You may fill out of some kind of a form, but you don't really have that summary of how you filled out that form. So we think it's an opportunity to have people in it's like an education piece of knowing how you have not just how you filled out that form, but also it provides for each of the risk factors that I identified, what they mean and why is that important to know. And again, this is all about providing education about Why do we look at certain factors as being important? So the next part of the tool is really around priority setting. So what the user can actually do about their health risks. So those are some of the lifestyle areas that I mentioned. And so in order for people to really think about what they're going to do, we can't be we can't be expecting people to be addressing every single thing. And this is why there are some issues around non-compliance, is because people get confused about all the different advice they get from their primary care clinicians to their specialist clinicians. They're often conflicting. So, and the other piece is that it's too much information. So why not allow not participants, but the users to then select the areas they want to be working on and they're comfortable working on and they're ready to work on to relieve some of that pressure. So for example, in this case here on the right side, if this particular person had four lifestyle areas come up according to their health risk questionnaire assessment, so they could work on their diet, their caffeine intake, their alcohol intake, and becoming more active. So now at this point, we ask the user to select 1 to 2 areas that they would like to start with. So not to put all that pressure on, but just to really think about what it is that they're ready to work on first. So that's the first part. Then they go into this action planning phase where, for example, this person who filled out the risk assessment questionnaire has diabetes and depression. And so based on that profile and everything else that was on that assessment, we would generate a recommendation for example, for nutrition, which is what's showing here, which is fruits and vegetables, servings per day, milk and alternatives, 3 servings per day, and so on. So that's the recommendation. And then we can actually have them actually track those recommendations if they want to put that recommendation into action. So, for example, for their diet tracker, there's a recommendation, and then they can put in the drop-down menu, today I had 3 servings of fruits and vegetables, 1 serving of milk and alternatives, and so on. And then they can see what's on their plate based on that tracking. And so they can every day go in there and track exactly what they ate. Similarly, for the physical activity tracker, there's a number of activities there. As you can see, everything is picture-based because our co-design team of older adults, and there's some evidence for this as well, that this is a much easier and more digestible way and a much more pleasant way of being able to track activities if you see the pictures. And then there's a drop-down menu there to show you, so that you can indicate how many minutes per day you engaged in that particular activity. So this tracker is really there for you to be able to take that action plan and then actually track your progress. So that's where the progress checker comes in. You can actually, for each of the lifestyle areas, you can actually see your progress. So that for a week, you can put in the dates that you want to see it, and you can see how you progress through some of the things that you had set out to do. There's also other features, but I'm not going to dig into too much detail right now. But the last one that I wanted to just show you is resources. So one of them is actually, we're quite proud of this. It's a video stories, and some of these older adults are actually part of our core design team, inspiring stories about their wellness journey, and that we're hoping that the users of KeepWell can actually benefit from by listening to their journey. And there's also other resources around their emotional, social, sexual, physical, and other disease-specific health-related information that they can look into if they wish. So those are the features of KeepWell in a nutshell. And there's others as well, but just not enough time today to really dig into too much. But I wanted to also walk you through what was involved to actually develop KeepWell. So a lot of our foundational work, it started off with using the knowledge to action model and an IKT approach, an integrated KT approach to guide the development, implementation, and then eventual evaluation of KeepWell. So we started this a long time ago. Our IKT team, so this approach of collaborating with all of our relevant knowledge users from the beginning of the project all the way to the end, was really successful. We had about 25 or so members consisting of geriatricians, family physicians, other healthcare professionals, eHealth technology partners, researchers, patients. So there's a wide range of knowledge users that were involved from the very beginning. We've had some, over the years, we've had some new members, some old members that have left, but we have had a core set of participants throughout the entire process. So we use the KTA model to really map out how should we develop this tool, how and who should be involved, and what should be the next steps based on what we're finding in our initial steps. So one of the first things that we did was a systematic review to really understand what multimorbidity intervention strategies work. So this was a systematic review and meta-analysis. And then we also conducted a realist review alongside this to really understand why and how and under what circumstances these types of effective interventions work or don't work. So this really set us the stage of thinking about what components or what elements should comprise a tool or an intervention that we will eventually create. So there was a lot of work done between the systematic review and the co-design. We spent a lot of time with researchers and healthcare professionals thinking through this. And then we had a co-design activity for about 12 months with patient partners. So one focus group per month for about 11 months is what took for us to, design what this tool should look like. That's when we named it KeepWell. And we worked with a technology company to help wireframe the tool and to actually develop the prototype. So then that led into a set of usability and pilot evaluation. So we did heuristics testing, and we also did some think aloud methodologies for usability, as well as a pilot evaluation for the KeepWell's functionality, feasibility, and usability. So this was a three-phase study that we did. And then we made a number of iterative changes for each phase of that pilot evaluation to then come up with KeepWell, the actual KeepWell tool prototype. And so we created the final version that was then ready for evaluation. So this was like a long journey to get to this point. So now I'm going to talk a little bit about the actual evaluation piece. So this was a 6-month hybrid effectiveness implementation hybrid design. And the objective was really to look at the effectiveness and the implementation of KeepWell. We used the type 2 type of this hybrid model because there's a little bit of information about self-management tools, but not enough in this particular context of it being a customizable technology. So we wanted to have equal emphasis on the effectiveness and the implementation when we did this evaluation. So the population of interest was older adults, 65 years or older, with one or more chronic conditions and or a risk factor, English speaking, able to consent, and have access to a computer or tablet device, which back then was something that we need to pay attention to. I recognize that nowadays that almost everybody has one of those, even older adults, but at that time it was still emerging as being commonplace. So our sample size calculation identified that we needed 220 older adults per group to be able to detect a significant difference in outcomes. We did a one-to-one randomization of the intervention or control, which was just usual care. Our allocation was concealed. And our primary outcome was self-efficacy. And we had a number of secondary outcomes related to quality of life and all the different lifestyle factors that I mentioned, social connections, e-health literacy, and a number of implementation outcomes, which I'll get into in a moment. And so our data collection was primarily through the risk assessment questionnaire or that health assessment questionnaire I mentioned, which was embedded within KeepWell. And it included those demographic and other survey instruments to assess outcomes. We also collected data through the actual KeepWell platform metrics. This was all mostly implementation. And these were collected in 2-week segments, longitudinally at baseline, at 3, and then 6 months follow-up. So each segment was 2 weeks. So we had 12 2-week periods that we had collected and measured data. So this was, we used the re-aim framework to really operationalize our outcomes and how we are going to measure everything. And this was incredibly helpful. And I think this set us up for success in terms of what we set out to measure and what we actually did measure. It was fairly close. So our reach was really around looking at the proportion of older adults who participated in the study, their representativeness, their demographic characteristics. Effectiveness was done through the effectiveness trial, looking at primary and secondary outcomes. Adoption was all around the number of participants who completed KeepWell tasks or features that were used, such as the ones that I've already mentioned. For implementation, we really looked at fidelity. So the rate of process objectives achieved, the number of successful logins, the completion of the health risk questionnaire, generation of an action plan, all of those things. This is what the tool was meant to do. And so did we actually achieve that? And maintenance for us was really looking at KeepWell use over time. So from baseline to 3 months, from 3 to 6 months, and then from 0 to 6 months. So now I'm going to talk a little bit about the results, and I'm not going to dig in too deep here, but just to show you that we had 485 older adults that we identified, and so of those, after the eligibility process, we randomized 448 to 24 per group, and then we had a number of dropouts that happened, especially after 3 months. We had a significant drop of 57 participants. And this was, the reasons here are shown, but we were in the middle of the COVID-19 pandemic. So there are, we do have to think about what that particular event, the implications of that, and how it had an impact on our recruitment. And I talk a little bit about that in a minute. So at 3 months follow-up, we had 155 people in the intervention and 211 in the control group. But by 6 months, that dropout stabilized. We only lost another 9 people between that period. So we did end up with 146 follow-up for the intervention and 209 in the control group. So some demographics. So our mean age was 72 years, but we had a nice wide range from 64 to 94 years of age. And we had a nice representation from all across the country, from Central Atlantic, West Coast, Prairies, and the northern parts of Canada. So that was really nice to see that we did have some representation from that. The common chronic diseases, not surprisingly, high blood pressure, cholesterol, osteoarthritis was quite high, diabetes, osteoporosis, and depression, and a number of other diseases listed here. We had a very high number of participants who also reported other chronic diseases. And so these are listed here, and they were mainly around gastrointestinal cancer, heart-related, mental health, and thyroid disease-related conditions. So that was interesting as well. And the common risk factors that were reported, were most commonly, were most commonly, having a relative with diabetes, experiencing a fall in the last year, family history of premature heart disease, and first degree relative with dementia. Those were the highest reported risk factors. So the common disease combinations that we found were interesting. So these were the most common, and as you can see, I had a slide where it kind of highlighted. So diabetes was very high, and of course, high blood pressure and high cholesterol was combined with many other diseases as well. So now I'm going to just get into the effectiveness results. So as you can see, the primary outcome of self-efficacy was not significant either at 3 or 6 months, but we had a number of secondary outcomes that did. So physical activity was significant at 3 months and remained significant throughout the 6-month study. Social connections was significant at 3 months, but lost significance by six. Whereas the opposite happened with eHealth literacy. It was not significant at 3 months, but became significant by 6 months, which is, I guess, not surprising. And then some parts of the quality of life measure, EQ5D, the visual analog scale, was significant both at 3 and 6 months, whereas the actual overall score became significant by the end of 6 months. In terms of lifestyle factors, so other than physical activity, none of the other lifestyle factors were significant. Caffeine approached a decrease, but was not significantly different from control at the end of 6 months. So in terms of the implementation of KeepWell, so 94% of intervention participants created an action plan to manage their chronic conditions. So, which was great to see. There was about 4,700 logins, mean 15 logins per person. And participants most often engaged in tracking their lifestyle area, so about 81%. And 53% used the journaling feature. So I didn't really dig into too much, but there is a feature in KeepWell where you can have journal entries whenever you want. And people actually use this quite a bit. And this is a feature that was actually a last minute add-on by some of our patient partner co-designers that really encouraged us to try and fit this in. And we did, and we're glad we did because it was actually used quite a bit. So this is just a table that shows the number of logins between 2 and 3 months, 3 and 6 months, and number of times people clicked on the My Progress and the number of journal entries. And as you can see, for each of them, it does decrease over time, but there is a bit of consistency in the enrolled patients who did use it. So again, creating an action plan, and in terms of selecting a particular lifestyle area, again, it wasn't surprising that physical activity and nutrition were selected the most. And similarly, the number of times enrolled participants tracked at least one lifestyle area was quite high. And again, tracking physical activity and nutrition were the highest. This graph just shows us the number of biweekly logins by enrolled intervention group participants from baseline to 3 and 6 month follow-up. So the orange bars represent the number of participants that were enrolled in that particular time period. So you can see the time period at the bottom. So those are those 2 week segments. And you can see baseline, 3 month and 6 month follow-up. And as you can see, the logins dropped at that period 6, just before the 3 month follow-up. And then after that, oops, sorry. And after that, it sort of it went up again, and then it started to decrease over time again. But it kind of held steady once it dropped. I have lots of other graphs as well, but again, given our limited time. I didn't want to dig into too much detail, but we're actually working on writing up our paper right now, and that will be available hopefully very soon. So again, another graph showing the proportion of enrolled participants who selected, the different lifestyle areas. Oh, sorry, I keep jumping around here. So as you can see, the blue bar represents physical activity. That's the highest. Nutrition, of those two are the highest amongst the enrolled participants. And that of those that were enrolled, their use, were quite high, 55% or above. So now I'm going to just move on to just talking a little bit about the challenges and the lessons learned by my team. And mostly these are reflections from my experience as well as discussions with our team. And so one of the things that I wanted to highlight is that the recruitment was extremely challenging. So we had to rely on multiple sources to reach our sample size, and it actually took 9 months to do that. And you can see this poster here. This is what we use. This was our recruitment poster that we used to try and attract older adults to participate in our study. So I just wanted to walk you through what it took for us to recruit 440 participants because it was just an experience that I've never had before. And given the situation at that time, we were in the middle of the pandemic. I thought it might be helpful for others to think about if you're ever in a situation like that. Or I would love to hear others if they have ever had or struggled with trying to identify that number of people for a trial. So we started off very strong. So we have a connection and relationship with the Retired Teachers of Ontario. And they have, at that time, they had about 40,000 members. And so they have, a membership database that they sent out our poster to invite them. And so we had a very strong first response of 210 people that responded. And of those, I believe 155 or so were actually enrolled in the study. Then in January, we kind of hit like we hit a it was very quiet. We were not able to get any more participants through the RTO. So we started thinking about other ideas. So one of them was to put a Kijiji ad on the Toronto, North York, and Mississauga areas with our poster to see if we can attract anyone. And essentially a cold call because we didn't know who was reading this. I mean, there was some ways of attracting a certain population, but it pretty much goes into we don't know who was looking at that. But we did end up with two people that responded. So we started to think about other strategies. So in February and March, we connected with the CARP, which is a patient organization called the Canadian Association for Retired Persons. And we connected with them and they they agreed to send an email blast to their members through Niagara, Scarborough, Ottawa, Brantford, and then later to other areas across Canada. And absolutely no response. And then we also connected with the Alliance for Healthier Communities to get mentioned in their weekly bulletin, KeepWell trial poster, no response. So we started to get a bit nervous. Okay, what do we do now? So then we started thinking about, and I've done recruitment using this strategy before, is to put the poster in primary care practices of our partners and collaborators that were primary care physicians. So we did get a little bit of a response, so 32 participants, and then through snowball sampling, another two. So we had to really think about now, what else can we do? Because, here we are, May, and we still have half of our participants not recruited yet. So through a colleague, we actually were alerted to an organization called Asking Canadians. It's a strategy where people who are enrolled as members offer to complete surveys and they get a little bit of remuneration, such as, coupons, things like that, discounts on certain things. So we thought this might be a strategy. They have a database across Canada. So we tried this and it actually worked really well. So we got 102 that responded right away. We did this in batches. And then we continued that along in June. We got another huge number, 170 responses. And then July, our last batch was 65 responses. And this is what allowed us to then have to fulfill our sample size. So I just wanted to show you this because sometimes you have to really think outside the box or really connect with your colleagues and networks to figure out how to do this because you can't always do it with traditional means. And I would also be interested to hear if anyone else has some experiences around recruitment challenges and how they overcame those challenges. So the other challenge was that this rolling recruitment, it was effective, but it was very lengthy. So it took us about 18 months to complete the whole study, from recruitment to the final participant finishing their last 6-month follow-up. It was an 18-month process, so it was quite lengthy. And it was more variable than we expected. And then the participants didn't always complete follow-up assessments at the requested time point. So we asked them to do it at the baseline at 3 and 6 months. And this response time ranged from 1 day to 6 months. So some people didn't respond until later. So this really complicated our data organization and analysis. So it was a bit challenging. So another thing that was really time intensive was enrollment phone calls with 485 potentially relevant older adults by two research assistants. So they had to confirm their eligibility, their consenting capacity, explain the procedures of allocation. What does that mean? What do they expect? So the provision of login details. So everything and consenting, all of those different things. So it was a very complex process. The ethics approval was also difficult because at the time the technology was fairly new. This idea of holding data on a cloud-based server versus physical server was difficult for REB departments to really understand. So this was a lengthy process to kind of figure this out. Um, the technology-based tools in general, they require a lot of maintenance and ongoing technical support, which then requires additional resources. So who's going to pay for it? And what are the implications for sustainability and scale up? So we get money from grants to develop and evaluate these tools, then how do we embed them so they're sustainable and so they become part of routine care so we don't have to worry about sustaining it? And how do we scale it up if it's not sustainable? So these are all questions that I'm very seriously thinking about moving forward, and also and curious about how other people handle this kind of situation. And overall, if I reflect back, it took too long to develop KeepWell. So everything from the foundational work to the evaluation. So how do we balance that rigorous methodologies to make sure that we co-design, to make sure that we have the right features that people need? How do we balance that with ensuring that implementation and scale up is timely and to ensure that the innovation remains relevant? So I think that's a really a big struggle that I went through. So overall, developing technology to working with technology partners, there were a lot of unexpected delays or situations. We had a great partnership with our tech company, but there's a lot of turnover with tech firms. So that relationship building piece can get lost and it undermines the progress that you make because you have new people, you have to re-explain and all of those things. It all adds time. So in our case, our technology company was acquired by a larger company, and then that larger company 6 months, not even 6 months, maybe 4 months later, decided to drop our project. They did not want to support it. And we were about 1 month out from finishing our trial. So we made a deal with them that they would keep it open just so that we can finish our trial. So after everything that we've gone through, then we had to deal with that. And so the other thing is the research priorities that may not align. So that scientific rigor versus, developing something quickly. So finding a balance is really tough. So who owns the IP? This is another thing that we struggled with. And when we went through this whole dropping of our tech company, we quickly found out that IP is different parts of the tech is owned by different people. So we owned the IP for the content and design, so the look and feel, whereas the tech company owned the IP for the back-end development structure that supports the app and how it operated within their cloud-based platform, because that's the piece that they innovated on. So then what happens when you want to make this available more widely? Like, how does that work? And we, as in researchers, and I don't want to speak for all researchers, but I struggle with understanding how to do that. We were not trained to think this way. And so, how do we deal with that? Who do we talk with, and how do we make that happen so that we can create technology that can be sustainable and scaled up without having to worry about all of these different things? So then the potential influences of COVID-19. So this definitely may have affected our recruitment processes and rates as well as our dropouts. So personal health reasons was one reason. So that may be related to the COVID-19 pandemic. It may also have more changed their or influenced their motivation to make lifestyle changes. I did a little digging in the literature, and it actually showed that globally, the pandemic actually didn't really have much impact on physical activity in older adults. And in some cases, it actually decreased physical activity. Except for Canada, they did see that there was an increase in physical activity, about 30 minutes a week more than before the pandemic. So in closing, I just wanted to just close off by saying that the results of our trial showed significant increase in physical activity, aspects of quality of life, and e-health literacy. And the implementation data highlighted some features that have been that show the best potential for helping older adults with self-management. And so, in terms of our next steps, we want to include adapting KeepWell for older adults with diverse sex, gender, race, newcomer status, and cultural, linguistic, and contextual needs, because that's much lacking. Incorporating an AI-based health coach, incorporating a social frailty module. So, my PhD student Crystal Amog's work will fit really nicely into KeepWell, as well as some work that we've done on caregiver support that could be incorporated into KeepWell. And of course, integrating KeepWell with primary care and replicating our study more broadly would make the most sense as next steps. So the way we imagine that is that primary care providers would prescribe KeepWell as a self-management strategy alongside clinical management of multiple chronic conditions. And our systematic review actually showed that that may be the best next step as well. So that's really where we're thinking about next steps. And with that, I just wanted to acknowledge the many, many people that were involved in this project. This was an incredible undertaking over the past 7 years. So I just wanted to really acknowledge and thank them for their support. And now I'm happy to take any questions you may have.
Thank you so much, Dr. Kastner. That was an amazing presentation, extremely comprehensive, going from the intervention to the challenges and lessons in conducting the trial. So that I really enjoyed it. So thank you. So you can all write down your questions in the chat using the everyone function. While we wait for some questions to come in, I have many questions I could ask on different aspects. But I guess the first question I would like to ask is if you could talk a bit more about how KeepWell is different from some of the other lifestyle tracking apps that you've seen in the context of your review of what's out there and what's existing before developing the intervention.
Yeah, thank you for that question. So I think that the biggest difference is that what we really tried to do is this idea of customization, the idea of really listening to what older adults want and need and can handle when it comes to multimorbidity management. And I think that when we set this out, like we actually literally hand organized an algorithm with our clinicians. It was a crazy amount of work that can now be done probably more in a more automated fashion. So I think I see like the idea that we had was innovative that we hadn't seen before. But I think that that's really catching, you know, right now everything is about customization. And I think it's much easier because we have the technology to do it. But I think that piece is I think is really important to really to really listen to what people need and want and to be able to address their needs in some way. So it's customized.
Fantastic, thank you. Um, Someone asked in the chat, is the KeepWell application used on smartphone, cell phone?
So that is a plan. So this was developed as a web-based app. So in the next phase, we have to get some funding to be able to do that. That is the plan to make this into a native app and make it a little bit more usable for other. So it was designed for computers and tablets, but to make it available on smartphones as well.
Sounds good, thank you. One other question I had is concerning the effects of the intervention, right? And that you did not observe effects on self-efficacy, but you did observe some other effects on the secondary outcomes. So I was wondering if you could speak more about, I mean, I guess your post-mortem understanding of the mechanisms of action of the intervention. Like, do you think it had effects in other ways? Not through self-efficacy, but some other mechanisms to then have effects on those secondary outcomes.
Yeah, so yeah, we're not sure, and this is always such a hard thing to kind of identify a primary outcome. Like, and for us, this was really more of a pilot trial. We wanted to see, is this feasible to do? And, we wanted to really see what features of KeepWell, are resonating with older adults. What are things that are like nice to have, but it's not really. And so it's really hard to answer that question because we were doing this over the pandemic. So even though, I mean, I really can't speak to self-efficacy. It's very difficult to to attain a significant self-efficacy of any intervention. It's very, very challenging. And so maybe that's not the right outcome to look at. I'm not really sure. But I think what we were really, I'm not sure if I'm answering your question, but I think what we were really trying to figure out is what are the things that people pay attention to that they find useful. And then, in the next iteration of the tool, we'll probably go through another set of, we're going to revisit some of those features and see. I mean, things change too. They evolve from like, what we did 5 years ago may not be relevant now. So it's kind of it's a tricky thing.
Tricky question, but it's an interesting. Thank you for your answer. So we do have a number of other questions in the chat. So from Julie Waddick asking, do you think a rollout strategy beyond the study would take insights from the recruitment challenges?
So if we were to roll this out, let me see here. Uh, yeah, definitely. So I think that now we know what we experienced. So one of the things we don't know is whether or not we had challenges with the recruitment because of the pandemic, or is this just would we have encountered this anyway? So I think that there are probably it may be easier now because I think people are more connected now than they were before the pandemic. And so I think we can probably learn a lot from that. So I think like what we learned from I think we can probably manage that better than the way we did. And maybe partnering more with more organizations would also help support that. Plus, I think one last comment about that is that because the next phase will involve more primary care involvement, I think if we had the primary care clinics and clinicians be active recruiters I think, for our participants, I think that might make it easier as well.
Thank you. Cynthia Locker asks, thanks for sharing the whole story of KeepWell, Monica. As you had to pivot on recruitment strategies, were there challenges with ethics? And through the Ask Canadians, were most respondents validated as the population you were seeking?
Yeah, great question, Cynthia. Nice to hear from you. It's been a long time. Um, so yeah, we did. So we had dozens of amendments to our ethics. So that was the first thing. And for the asking Canadians, like we treated this exactly the same thing as with other recruitment sources. So this was really just people asking people to contact us. And then we would set up a recruitment phone call and then we would go through the whole enrollment. So we verified, like, if, we asked for, older adults, 65 years or older, with multiple chronic conditions. And once, they wrote to us, then we confirmed all of that through our enrollment phone call.
Excellent. Diana Pernigotti asks, regarding the recruitment challenges, how was the snowball effect supported, and were you able to pinpoint some of the activities that work best in supporting that?
Great question. So we didn't really do too much of that. All we did was we asked our participants if they had anyone else that they could suggest would be interested. So in some cases, I think there were more. I think there was two snowballed from that one, but there may have been a couple more from my memory. And some of them were, the partner of the one person that we recruited. So that happened a lot as well. But we didn't formally, so that could be another piece that we could further explore in our future work is to be more deliberate about snowball sampling.
Excellent. We have two additional questions. So Susan Jaglal asks, could you talk a bit more about eHealth literacy? Do you have to offer assistance to participants to use KeepWell?
Great question, and nice to hear from you, Susan. So e-health literacy was like one of those things that we wanted to measure because we purposefully created KeepWell for older adults of any health literacy. So that wasn't a criteria for eligibility. So we wanted to create KeepWell for anybody, whether they had previous experience with technology or not. So that was a really major objective for us when we co-designed this with older adults is we wanted to make sure that it was user-friendly and that it did not require training. So we went to extraordinary lengths to create these instructional videos. I didn't mention this, but there's about 5 instruction videos that are available as part of the app where it walks you through how to fill out the health risk questionnaire, how to set your goals, how to create an action plan, all of those different things. We even had some buttons on ask for help. So we had all of these different things embedded within KeepWell to make it as standalone, without assistance, without training as possible. So, and I think we did that job well because we hardly had any like technology issues. There was only 3 people that withdrew from the study because of technology issues. So we thought that was a win. And it's one of those things that, and I think it did improve over time. So we think that maybe the experience with Keep will help them to navigate better an app such as this. But yeah, it's hard to know. Like there's no direct relationship that we can say.
Excellent. Penny L says, thank you, Dr. Kastner, for the interesting presentation. Would you approach the challenges experienced with the tech company differently looking back?
Yeah, that's a great question. I don't think so because I think we did everything in our power to build a relationship. They were actually part of our grants. We had 2 large grants that helped support this work, and they were part of that application. So we had a really great relationship. The problems started sort of midway to the end, And so we just learned a little bit more about the industry in general, like how that works. And as researchers, we think very differently than, the private sector and in those kinds of ways, in terms of, it's more of a business. We're developing a product, um, so I think what I would do differently, or like if I could give recommendations to anyone who's starting this, is to really learn a lot about how it works. Talk with with, you know, every university, or not just universities, but every research institute has departments that you can speak with to give you advice. Partner with the right people to help you understand how things work. I kind of just learned it along the way, but if you do kind of like that legwork at the beginning, that will probably help minimize any kind of issues that I mean, we couldn't have anticipated that the company's going to be bought out and then go under, but those things happen, obviously, and actually quite more frequently than we imagined. So.
Excellent. And then we have a last comment saying primary care clinics are one of the best resources for patient recruitment, but how to advocate and encourage family docs to participate in the recruitment is another challenge.
Yeah, absolutely. And I think what we've found we've been very lucky because a lot of our primary care partners have been incredibly supportive and engaging. And I think it's all about relationship building. And I think if you can show value in what you're doing and that the potential, I think that goes a long way. And it's just I think it boils down to relationship building and seeing the value.
Well, I think we're pretty much at time, so I see no other questions in the chat. So last call if there's any any other question. I guess I'll close by asking just a very brief question, Monica, around engagement and sustained engagement in the intervention. So do you have a sense that the people who left, or I guess used because you did have a bit of a drop off, right, in the use of the application over time. Do you have a feeling that that was to be expected? And do you have any insights on strategies to sustain engagement for
Yeah,
you?
so it was expected. There's this thing called voltage drop that happens with implementation. And so we did see a little bit of that. It's a very difficult thing. And maybe if we would have ran it even longer, it would have been even more. So that's probably the $1 million question, because that's something that's what we strive for, is to have the continuous sustained excuse me, engagement. So yeah, it's a difficult one. And I think if it becomes part of routine care, such as primary care, it may be a better way of getting people to stick with it.
Mm, right. Yeah, with feedback loops with their
Mhm.
provider and so on.
Exactly, because then would work together alongside clinical management. So I think together it would be a really great.
Excellent. Well, thank you so much, Dr. Kastner. Please, everyone, thank you for being here, and please complete the evaluation. So Megan has just put the link in the chat, and thank you so much for attending. Thank you again, Dr. Kastner, for the talk and the Q&A.
Thanks so much, everyone. Have a good
Good day,
afternoon.
everyone.
Thank you. Thanks, Monica, and thank you, Guillaume, for moderating.
Thank you. Bye bye.
Take care.